Good morning, everyone. Welcome to our symposium on the substance use disorder and polyabuse. My name is Mario Miccoli. I'm full professor of psychometrics at the Mercatorium University of Rome. I would now invite the first speaker, Professor Angelo Maremmani, presenting his work on the neurodevelopmental disorders in substance polyabuse, clinical and therapeutic aspects. Professor Maremmani is Associate Professor at the St. Camillus University of Health Sciences in Rome. He is the President of the Italian division of the World Association on Dual Disorders.
Thank you, Professor Miccoli. Thank you very much. Thank you, all of you, for coming from our symposium. So I will try to give some notes and some insight about our work and about the neurodevelopmental disorder and substance use disorder from a clinical and therapeutical approach. I will focus mostly on ADHD, showing some of our research on the topic and some literature in the complex comorbidity between ADHD and substance use disorder. Just to give you an idea, I will give some insight about the clinical consideration on diagnostical issue on the diagnosis of ADHD from childhood to adulthood. And then we will focus on ADHD and substance use disorder from a clinical and therapeutical aspect, trying to sum up some recommendation at the end. When we talk about neurodevelopmental disorder, the DSM-5, just give a list of disorder. And you know, sometimes the diagnosis and the clinical presentation should be easy as this one. So very easy to make a diagnosis and following the proper treatment. The problem is that most of the time we ended up with a very complex comorbidity. And it's very unusual to find even a child. I'm a psychiatrist for the adult dimension, but even in the neuropsychiatrist field, it's very tough to find just a single specific diagnosis. And you can see the broad of overlap in this area. So what we can see then in time is the trajectory that these disorders can have during time. You see that we are used to have this kind of aspect. You see the normal trajectory and evolution of the ADHD from childhood to the adulthood. It would be a reduction in the hyperactivity and impulsivity trait. This is something that usually happens in an ADHD patient becoming adult. And then there is most usually the persistence or the worsening of the inattentiveness symptomatology and impulsivity. And this is very important for the starting with substance use. And of course, the persistent and worsening of emotional dysregulation. Another very important aspect is the modification of the environment request, performances, the goal in life. So sometimes the diagnosis cannot be done under the 6 years old, but when kids are 10 years or more, because it changed the performance and the goal that the kids have to fill. And another very critical aspect is the high level of comorbidity. This is the moment in which this young adult came for the very first time, sometimes, to psychiatric consultation. And so this is the problem, and this is why it's so complex also to make a diagnosis in the adulthood. Because we start from a very complex and overlapping situation in the childhood. We have a high comorbidity level and percentage, and then we usually find the starting of a toxicomanic process or substance use disorder as well. So we have some hints that we can have to start to focus and I would say to think about ADHD in our patient. So it's very possible that we start a consultation with one of our individual or client And we start to think about bipolar disorder, depression, anxiety, impulse discontrol. But sometimes I'm talking about our nation, at least in Italy. We lost our focus on the ADHD because we are more interested in anxiety or affective disorder. As you can see here, there are a lot of symptoms that can be overlapped in the two situations. But if we go very specifically on the clinical significance of the dimension of the symptom, it's very possible to refer to an ADHD dimension. And specifically here, there are 4 very interesting aspects: the sleep problem, the emotional dysregulation, the excessive mind wandering, and the executive function alteration that are specific for a clinical presentation of ADHD in the adulthood. This is one of the room, a picture of one of the room of individual with adult ADHD. You can see here they start consultation for psychiatric comorbidity. They tend to procrastinate. They have a chaotic lifestyle. They have planning problems, work instability. A lot of this aspect seems to resemble mood instability, emotional dysregulation, psychiatric comorbidity that maybe as psychiatry at the adulthood we are more used to deal with, you know? But then this is what the clinical presentation comes up. If you see the ADHD only in the children and adolescents are just 1/3. And then there are a lot of overlap with other dimensions. But in the adulthood, the pure ADHD diagnosis reduced to below 15%. And as you can see here, all the overlap of the other comorbidity were very broad. And the percentage of our subject affected by substance use disorder or alcohol use disorder, it's very, very important. I would say impressive. So what can we know? What do we know about substance abuse in an ADHD individual? Of course, all this situation just get a worsening in the clinical presentation and, of course, even in the outcome. There is an early age of onset of substance abuse, usually below 13, below 12 years old. So it's very, very, very early. A higher likelihood of use of very different substances. So not only a mono-use substance, but the polyabuse. Increased likelihood to suicide attempt, more hospitalization, less likely to achieve abstinence, and of course, a very high rate problem of compliance and treatment adherence. We know that individuals with ADHD are 3 times more likely to be dependent for nicotine and 3-fold time compared to the peer associated with the subsequent drug use disorder. And this is something that it's very important to keep in our mind, that the treatment and the pharmacological medication are very important in this population. And it's not important only to treat this patient, but also the time when we start our treatment, because we are in a condition in which the treatment start early, we can really, really modify the trajectory of this disorder. So the early age of initiation can really, really reduce the onset of a subsequent substance use disorder. But not only this one. Treatment is not important only to avoid or to reduce the risk of a forward substance use disorder, but also the risk of death for unnatural causes. So we can use very powerful medication for a disorder that is very, very complex to see in our clinical presentation. Our recommendation is looking for ADHD in our patient and treat ADHD when it's possible. And this is very important because using pharmacotherapy, we can reduce dramatically the risk of substance use in adulthood, and the therapeutical approach reduce the development not only of substance use, but also a substance use disorder in the early stage. Trying to give more insight into this topic, we will try now to understanding more the approach between different kinds of substance of abuse, the fact that it's very rare to have some patient affected by a mono addiction, but we are more dealing in the field of polyabuse, and then try to select if it's better to treat this patient with stimulants medication or with not stimulant medication. And then another critical aspect is in a subject affected by a polyabuse, which kind of treatment approach or hierarchical approach can we find, especially when we deal with substance affected also by opioid use disorder. If we are working in an addiction unit and we are looking in the whole, in all of our patients, maybe if we start to screen for ADHD, it's very important to understand that 1 out of 5 of our patients probably it's affected by ADHD if we use a tool screening just for them. And if you look in the literature, you see a very wide variety of number. Here, just to sum up, is the prevalence that we can find in an ADHD patient. Opioid use range until 30%, alcohol up to a half, cocaine up to 1/3, and various in this topic, in this item, even cannabis is considered up to 50%. So there is not just one specific substance that is the best for our ADHD patient, but as you can see, a lot of different substances can be used. But one of our important concepts and topic should be introduced when we talk about substance abuse in this specific disorder. And this is the self-medication hypothesis. It's very important to give some information about this theory because the idea is that substances are not using just for their reward aspect or for their reward potential. As a patient would say, I'm using this substance because I like it. I look for the reward of this substance. But it's not chosen randomly. Actually, there is a tight interaction between what? The psychopharmacological action of the drug use and the dominant painful feeling with the patient is struggling with. Okay, so there is a specific matching and a combination, such as use of sedative for anxiety, and in this situation, maybe use stimulants, drugs, and medication to reduce some symptoms of ADHD, for instance, the inattentiveness, to improve their attention, and of course, also to give some relief craving for their restlessness. So we start in our, in the clinic, we used to work in the last year at the University of Pisa, a few paper and work looking for, try to have more insight about the specific psychopathology and clinical feature of our patient. And we find out that polyabuse was very, very frequent, and reward and relief craving can coexist in different stages of the toxicomanical process of our patient, and we try to find if there was possible to divide our patient in different clusters, different dimensions of substance use, and we find the differences in type 1 and type 2. This is how we call this. Our patient with type 1 more characterized by use of stimulants and alcohol, and the type 2 more characterized by cannabinoid use. As you can see here in the slide, the type 1, the one characterized by stimulants and alcohol, were younger and with more legal problems, but the two patterns were very, very, very similar in terms of ADHD specific symptomatology and in the severity of the treatment. Why is it important to focus on this difference? Because this would be very important for a therapeutic point of view and approach. If we divided our patient according to the type 1 and type 2, we find out that the type 1, the one using stimulants and alcohol, were more characterized by a relief craving. So the use of stimulants were using in order to self-medicate in somehow to cope with inattention and restless symptoms. So the predominance of relief craving was the one that was show a better response to specific treatment for ADHD. On the other hand, the reward craving was the one that characterized mostly our ADHD patient, characterized by the use of cannabinoids. In this situation, the predominance of the reward craving were even characterized by the presence of major psychiatric complication, mood instability, impulsivity, and the use of medication for ADHD show no good response in the use of cannabinoids and substance of abuse, and we will see later. So we start thinking, we always have in our mind that the gold standard of the medication for addictions, that is the agonist opioid treatment for opioid use disorder, right? So we think maybe using the long-acting stimulants medication, we could also have a benefit in stimulants use disorder. But the answer is no. Because this is something that we saw quite clearly, that cocaine use disorder without ADHD, they were driven mainly by reward craving. And we know for literature that the use of stimulants in the treatment of stimulant use disorder, cocaine specifically, they are not ended with a good outcome. What is different is when we have a cocaine use disorder ADHD individual. This is very important because this specific combination of the two, this comorbidity, when it's driven by relief craving, we can have a very good outcome in the substance use disorder because the medication treats ADHD, and we have a consequent good benefit on the use of stimulants. There are also some neurobiological studies that look at this actually and see how patients with this comorbidity may experience a short-term advantage in cocaine assumption for a compensation of dopaminergic deficiency or related cognitive behavioral deficiency. And what we look at this is one of our study, is the very important, remarkable reduction of cocaine use for our ADHD, cocaine use disorder patient that were treated with the stimulants. So in some way we can follow the idea of a self-medication hypothesis in this specific population due to the use of stimulants because they are ADHD patients. And this is complicate even more the clinical presentation. Because of course, if we are saying that the use of stimulants and cocaine, it's a good thing to self-medicate for ADHD people, it's not so clear. Because the very first time in which our patient use the stimulants, they can self-medicate because they can have a relief craving and they can continue in the use of cocaine. This is the beginning, because of course, at the end, we will go to a much more complicated clinical presentation in which the two disorders, the ADHD and the cocaine use disorder, will sum up, creating an even more complex clinical presentation. This is a model of pathophysiological perspective of how these two disorders get entangled together. You see the ADHD individual, when taking cocaine, they can, yes, reduce their symptoms of inattention, okay, and then implementing the relief craving. Of course, cocaine in time is a very fast-acting and dysphoric substances. So in this time, the two disorders get the worst of each other. So at the end, when we start to use therapeutic stimulants that have no dysphoric effect, that are more stable, even the need for cocaine can be reduced in our patient. So you can ask me, and we can think about, are we able or should we prescribe stimulants to an adult ADHD patient using substances? And the question, I think, could be answered with a yes. Yes, because the use of stimulants medication do not precipitate substance use disorder in adults that were not affected by addiction before. And the ADHD treatment in substance use disorder patients can be useful to reduce ADHD symptoms without the worsening of the addiction of the substance use disorder in the effective. And again, ADHD pharmacotherapy is associated with a short and a long-term retention in treatment. And ADHD medication decrease substance abuse up to 4 years after medication. And the longer is the treatment, the longer is the outcome. You see here in the line the comparison between the two groups. The one in blue received medication for ADHD. They have a retention in treatment that is better compared to the peer that have not received ADHD medication. What about the use of other kind of treatments, such as not stimulant 1? I'm talking about atomoxetine, because in Italy we only have this one, and in the last year we have not the possibility to prescribe anymore. But the point was that some experts, if maybe we can have this same topic and presentation, I would say 10 years before, maybe we would make some recommendation and start to use not stimulants medication before the stimulants 1, because of a series of recommendations. So the risks of using stimulants can increase substance of abuse in our patient. But in the last year, and the data I showed you before, show us and tell us that there is no risk of worse or increased substance use disorder if we start to use stimulants at our first choice. And this is something that is for sure more effective compared to the use of a non-stimulant medication 1. Why the use of stimulants is safe? Because the slower the rise and fall by the stimulants, and lower is the risk of misuse. Of course, we have methylphenidate in Italy. Only this is the only treatment available for ADHD in Italy, unfortunately. But of course, a patient of mine affected by a dual disorder with an addiction, I would never prescribe immediate release methylphenidate, and I would recommend and prescribe the extended release, because it gives me a lot more confidence in the stabilization of the dopaminergic system. And do medication reduce, ADHD medication are able to reduce the substance abuse in ADHD individual? The answer is yes, but the reduction of the use of substances is mainly driven with the better outcome of ADHD. And this is the reason why, if I'm treating a cocaine use disorder without ADHD with this medication, I do not have effect on substance use. The effect on substance use is driven by the better outcome on ADHD. Another very important issue is the dosage. We used to prescribe low dosages because we think to be more safe in some way. But the thing is that even different research group and the literature told us this, the higher dosage of methylphenidates, up to 40% compared to the standard dosage, show us the better outcome for our patient. As you see here, there are 4 years of this study in which a substance use disorder treated with ADHD medication and methylphenidate show, as you can see here, yes, there is a gap in the dosages, up to 40%, that is stable in here. So we do not even to increase, we do not have tolerance to the effect of the medication. And lastly, going to the end of the presentation, what do we know about opioid use disorder and ADHD? Because opioid use disorder is a specific disorder that is pretty often in our patient, as we see. And we perform an interesting study in which we screen for ADHD symptomatology, so they are not the disorders, in a group of individuals that were treated by this colleague of us, Dr. Pasqualina Rocco, that screen all of these patients and find out a very high percentage of individuals with the high symptomatology for ADHD. And if we compare the group with the ADHD high symptomatology with the one without ADHD high symptomatology, we saw that there are no differences in the retention in treatment. But please note that all these patients were treated with high standard of opioid medications. So the Dolenized Wonder methodology, the blocking and anti-craving dosages were followed strictly for every one of these individuals. The point is that there probably are interaction between opioids and the dopaminergic system. And so, as you can see here, chronic opiate can show a reduction on the density of norepinephrine and dopamine. So high dosage of methylphenidate can be a breach showing the activation of mu receptor and suggesting the possibility to have a compensation between these two dimensions, the opioidergic one and the dopaminergic one. And of course, the activation of the kappa receptor is also being shown to decrease the frontal cortical dopaminergic release. This is very important also from a clinical point of view, because the paper I show you, the retention in treatment was the same for the two populations with ADHD symptomatology and not, but that population, no one of that one were treated with ADHD medication. So how could it possible that they have the same retention in treatment? Probably the effect of opioids to a proper dosage has stabilized the dopaminergic system, and acting with the dynorphinergic and the kappa reception can interfere in some way with the release of dopamine to the system, to the frontal cortical release. You see here the activation of the kappa system produced dysphoria, analgesia, depression, and decreased the release of dopamine. On the other side, the deactivation of the dynorphin system can be, as we know, antidysphoric, stabilizing the mood, improve the cognitive function, and, of course, make a favorable release and pulse of dopamine to the frontal system. This is just in some idea of the action of one of the two medications we have, buprenorphine in this way, that can act as KOR kappa antagonism. And this is very interesting that atomoxetine, that is specific for the treatment, is in label for the treatment of adult ADHD, can show some partial agonist effect to the kappa opioid system. It's very important to consider this aspect of the dosages, because we know how critical is the prescription of the proper dose to have a correct treatment for opioid use disorder. Because if we start to see other paper, all of other paper tell you that opioid use disorder individual have with ADHD has a reduced retention in treatment, a more severe clinical presentation. And this is true, but I would just want you to take a look to the urinalysis and to the dosages that this patient probably have during a maintenance phase. Again, here are the same consideration, but again, the dosages of our group are different from ADHD1 and no ADHD with opioid use disorder, but the maintenance dose is lower than expected to a Dolenized Wonder methodology. So in the end, we are not talking about strictly guidelines, but we are more talking about clinical recommendation. Of course, we are dealing with very, very complex clinical picture of our patient. And again, we need to prioritize probably the disorder that is get more instability to our patient. If we are talking about bipolar disorder and ADHD, our patient is in a manic episode, we need to stabilize the mood before treating ADHD. When we are facing with opioid disorder or other addiction and ADHD, we need to stabilize the disorder that is more worse in that moment. We surely know that if the treatment with stimulants is really, really effective in the childhood, it comes to be more problematic, the outcome in the adulthood. So it's very important to start as soon as possible, because if we start later on in life, when we have a long toxicomanical history of our individual, the effect of the medication, we will see the effect of medication, but the medication effect will be reduced and probably less effective in time. This is one of the considerations that we published recently, and just a picture to understand you how tough it is in Italy to treat this patient, because we are divided in addiction unit service and the psychiatric service. The prescription is very complicated, and so we need to work together in a very collaborative way with a reduced number of medication available. This is a special issue. I'm leading for the JCM and about dual diagnosis and dual disorder, and this is very important to me and for us to continue to work in having a more holistic, a broad approach to this disorder. And so I really invite you to submit to the paper your research. I would be very, very grateful, and I thank you for your kind attention.
We thank Professor Angelo Maremmani for his interesting presentation. I would now ask the second speaker, Professor Icro Maremmani, to start with the report of the work on the principles of the treatment of opioid disorder from polyabuse to psychiatric comorbidity. Professor Maremmani is the president of the European Opiate Addiction Treatment Association. He is the president of the World Federation for the Treatment of Opioid Dependence and vice president of the World Association on Dual Disorders.
Thank you, Mario, for your kind presentation. And hello, everyone. Today we will be discussing a topic that is as old as I am. The problem of opioid dosage when dealing with heroin addicts who are polydrug users and have a dual disorder. This is my disclosure. The methadone treatment has a long history. The story was born with the intuition of Dole and his wonder that starting from the idea that drug addicts should be considered sick, it is necessary to find a medical treatment that benefits them. You certainly know that Dole and his wonder are famous for using high doses of methadone, but they used high doses of methadone not to test a therapy, but to resolve an error. They thought, in fact, that by administering as much morphine as the subjects requested, the patients would be fine. Instead, they had to stop the experiment because the patients were getting sicker. In addiction, their tolerance was so high that they had to use higher doses of methadone to begin the detoxification. However, patients with high doses of methadone returned to a normal life, but also quit heroin use. The revolution, therefore, was to move from detoxification to maintenance, but the problem of dosage has always been present. What do we know after 60 years of methadone maintenance? First, we know that the toxicomanic behavior may be controlled by a range of different methadone dosages for different individuals or for the same individuals at different times of their addictive history. Second, we know that some subjects can be stabilized with the dosages below 60 milligrams a day. In contrast, most of our patients must be stabilized on a dosage ranging between 60 and 150 milligrams a day. Third, we know that in some cases, subjects can require higher dosages, up to 1,200 milligrams a day. Fourth point, we know some subjects require minimal dosages, 10 milligrams a day, to be maintained long life. Therefore, to treat opioid addiction, we must first use an anti-withdrawal dose, and then a blocking dose, moving from the induction phase to the stabilization phase, in which we use a stabilization dose. Then we can move on the maintenance phase with the maintenance dose, and then reduce this dose until the medication is eliminated, if possible. So we must consider 4 types of doses: anti-withdrawal, blocking, stabilization, and maintenance. And this is the dosage of the first 3 years of patients with and without dual disorder. In the first months, the dosages for patients without dual disorder are slightly higher. Then, from the 6th month, the dosages are higher in patients with the dual disorder and are maintained even in the initial phase of disengagement. Look at Q8. The disengagement phase for the patients is interrupted, and the dosage are again in the stabilization range. So, during the treatment, we can go up, but also down, and up after down. Blocking doses is therefore necessary for the stabilization phase. However, they are also useful in protecting patients from overdose. The recent deaths in the United States from the opioid and fentanyl epidemic would certainly have been more minor if these patients had been treated with the methadone blocking dosages. During the student revolution in 1968, the students in Paris said, "Quand les doigts montrent la lune, l'imbécile regarde les doigts. When the finger shows the moon, the imbecile look at the finger." Faced with this catastrophe, policymakers have preferred to promote the use of opioid antagonists by drug addicts themselves. But do you think it's better to resurrect people or prevent the death? Is the blocking dosage, therefore, the one at which the patient no longer feels the action of heroin? No, that's not enough for us. The first of us to clarify this point was Mark Resinger in Kyiv, Ukraine, in 2012. He said, as a cruising dose, we often settle for the one that eliminates the lack of heroin and daily use, the so-called blocking dose. Stopping daily use, treating purely physiological or internal dependence, is only the first objective. There is a broader dependence involving the entire environment, dependence on places, times, people, which requires protection and higher doses of opioid agonist treatment. These doses must be increased until alcohol and drug abuse, spontaneous craving for heroin, and dreams of heroin, sometimes precursor to relapse, disappear. The appropriate blocking dose is reached when a patient can refuse an offer of heroin. Having established that the blocking dosage must be individualized, and considering the addictional craving for heroin and the hidden craving, so to speak, let's see when the blocking dosage is necessary and when it is not. The blocking dosage is necessary when we want to suppress a patient's craving for heroin, but also when we want to stop maladaptive behaviors, those related to infectious diseases and polyuse. Blocking dosages are necessary if we want to manage the pregnancy of our patients better and when a dual disorder is present. The blocking doses are not necessary when we are content to defeat the withdrawal syndrome and when we want the patient to improve his quality of life or, instead, his social adjustment. If we decide not to use blocking dosages, or if the patient does not want to block the blocking dosages, then it means that we are doing harm reduction and not treatment of heroin addiction. In this case, we move from anti-withdrawal doses of the safe induction phase directly to the maintenance phase with anti-withdrawal dosages or not. Still, in this way, it will be difficult to rehabilitate patients. Then we will arrive at the reduction of the medication without having achieved the actual rehabilitation. And the consequence will be early readmission. Patients return to treatment less than 1 month after the latest treatment ends. And this slide is also useful to differentiate harm reduction to comprehensive treatment. There is only one way to make harm reduction a willing strategy where treatment system can exist, be integrated with the treatment system. In other words, the approach must be biopsychosocial, and drug addiction must be faced according to the theory of different levels of intervention. The opioid agonist treatment approach was related to higher recovery and polyuse abstinence rates compared to the harm reduction approach, despite greater severity of substance use, psychiatric and physical comorbidity in patients in comprehensive treatment. Our results are consistent with the possibility to use lower maintenance opioid doses after induction and stabilization in methadone treatment, but only according to Dole and Iswander methodology. This seemed to be impossible adopting the currently accepted harm reduction model. So, I want to stress the importance of dosage and treatment times, and especially the importance of doing all the stage of treatment. If we divide the patients according to the stage of treatment and compare them with the patients in harm reduction, then things change even further. In this slide, you can see that in the first group, we have subjects who had been in treatment for a longer period, had an adequate period of stabilization, had reached good level of rehabilitation, and were gradually reducing their medication within a flexible framework. In the second group, we have subjects on stabilized methadone maintenance therapy who follow the program regularly and comply with the operators. In the third group, we have subjects who prefer rapid detoxification or do not adhere to our program philosophy. You can see that the people treated with the dosages around 20 milligrams showed a higher frequency of a good urine test outcome, but only after the 4 phases of Dole and his wonder methodology. On the other hand, we have well demonstrated that the lower the dosage of methadone in seriously ill subjects in an harm reduction program, the more craving for heroin and alcohol appear, accompanied by the presence of high psychopathology. And we have also demonstrated where Dole and his wonder methodology is used, craving for heroin, cocaine, and alcohol decrease significantly after entering into treatment using only methadone blocking dosages. We have seen that the blocking dosage must be individualized to achieve the best results, and it is never a fixed dosage. The same thing must be applied to stabilization maintenance dosing. There are, in our clinical experience, 4 levels of stabilization dose in accordance with the sort of opioid depth that the patient faces at the time, at that specific time. The first one is the severity of the illness with its tolerance to opioid. The second one is the possible presence of a pain syndrome. The third is the presence of a psychopathology, specific or due to a dual disorder. And finally, we must cope with the stress sensitivity of our patients. We don't have time to discuss this topic of stress sensitivity, but stress sensitivity should also be taken into account when adjusting the stabilization dosage. To monitor our patients during the treatment, I want to say that we should not only do urinary tests, but we should also collect much more information. Drug addiction history, psychopathological symptoms, heroin craving behavioral covariates, reaction to loss and traumatic life events, subjective wellness, cocaine problem severity index, and marijuana craving severity. If we collect information about our patient's sensitivity to stress, we can see that it decreases as the stabilization dosage increases. So, the reaction to life events is sensible to opioid medication. The stabilization dosage also influences the response to treatment in individuals with the dual disorder. Patients with and without bipolar I disorder have the same outcome. In this case, we used dosages around 140 for bipolar patients and 120 milligram a day for people without dual disorder. Both treatment, retention, and stabilization dosage are not statistically different, but bipolar patients tend to stay longer on treatment by taking higher dosages. Patients with chronic psychosis and without dual disorder have, after admission in enhanced methadone maintenance treatment, the same outcome. In this case, we used dosages around 115 in chronic psychotic patients and 120 milligram a day for patients without dual disorder. These differences are also not significant, but chronic psychotic patients tend to stay on treatment for less time and at lower doses than controls, but also than bipolar I patients. In all patients received stabilization maintenance doses greater than the standard doses, even patients we used as controls. However, the highest dosages are achieved when there is a strong concomitant addiction to benzodiazepines. These show that polyuse also contributes to increase the need of higher blocking and stabilizing maintenance dosages. If you do not normally use blocking or stabilization maintenance dosages in the form I have described today, please consider treating your treatment system. The ancient Greek maxim, "Knozi se auton," also applies to healthcare system, which cannot adequately cure the patients if they cannot cure themselves. Thank you very much for your attention.
We thank Professor Icro Maremmani for his engaging presentation. I would now ask the last speaker, Dr. Manuel Glauco Carbone, to start his report on the neurodegeneration in substance polyabuse, clinical and therapeutic aspects. Dr. Carbone is medical doctor at the University Hospital of Varese, University of Insubria in Italy.
Thank you, Mari, for the introduction. And thank you also, Angelo and Icro, for your presentation. Okay. Analyzing the lifespan of the subject, analyzing the lifespan of a substance users, this is maybe the right end of our symposium, because we will see the last part of the neuroevolution of an individual in general, and the neuroprogression of an individual with a substance use disorder. In our presentation, the topic will be the relationship, the strictly specific relationship between alcohol, heroin, and cocaine and their related neuroprogression. This is just the outline of the presentation. I know that are a lot of concepts, but I will try to summarize, to sum up all these things. giving an overview of the relationship about substance use disorders and neurodegenerations, examining some clinical data, and also offering an overview on the general neurobiological mechanism. As well, we will talk about the specific cerebropathy related to each substance, and also the link, the relationship between neurodevelopmental disorder and neurodegeneration through the substance users. And finally, some tips about the clinical diagnostics and some therapeutic elements, and some suggestions for future directions. Just to make a little premise of my presentation, we are witness of a global change in our population patients, because we know that the healthcare in general is improving right now. So we have in our clinical experience, in our clinical activity, a new part of a patient's population, because we could have long-term users of substance, because we can treat easily the medical comorbidity associated to a long-term use. And at the same time, we know that lifestyle is changing, as well nutrition, as well other environmental factors. So we will have in the next futures a new populations of patients. As well, we need to understand that aging in general, the physiological and the paraphysiological evolution, neuroevolution of the brain is strictly linked to the risk of develop a substance use disorder. As well, the neurotrajectories are very interesting, because we know that some delayed in the cortical maturation, for example in ADHD, are the vulnerable substrates of action of a substance. As well, the importance of early recognition, these dimensions, and try to treat as well. And we have to understand that we could have some target therapy, some personalized instruments to treat these patients. We know that in general, substance use disorders and the toxicomanic process shared some pathophysiological mechanism with neurodegeneration. For example, we know that at the basis in general of neurodegenerative disorders, so in which we include all type of dementia, all variants of dementia, like Alzheimer's disease, frontotemporal dementia, Lewy body dementia as well. But they shared with the chronic substance using neuropathophysiological mechanisms like oxidative stress, like mitochondrial dysfunctions, or also neuroinflammation processes. As well, the other part of the presentation of Angelo, the neurodegeneration, the evolution of the brain, is like a vulnerable substrate to develop a new addiction, because there are some brain regions mostly affected by this process that influence the addiction and the development of substance use disorders, like the prefrontal cortex, so the control of impulses, the capacity, the ability to an individual to manage the emotional and instinctual part of the subcortical structures, as well as striatal circuits, in which we could have some neuromotor syndromes, for example, or also the limbic structures. We have some clinical data. We have to take with caution this data, because we not have just standardized studies in which we have a comparable definition of long-term users, because some studies try to take patients with 5 or more years of continuously using of substances, other studies 20 years. So it's quite difficult, but in general we know that we can find neurological signs, also comprising soft neurological signs, in the 50% of the case of patients with a substance use disorder. As well, we can find some neurological signs in alcohol use disorder in 60% of cases. And in the case of alcohol, we have studies showing 10%, other 30%. So we choose 20%, in which we have a full-blown clinical presentation of dimensions related to the alcohol use. Also in this case, cautions with what we are saying, because in the majority of the cases we have a polyabuse, not only one substance. So it's quite difficult to understand which substance damage mostly a specific brain area, or if act another substance in this context. We know that there are a lot of risk factors that link substance use disorder to the risk of developing neurodegeneration. We know that genetic predisposition. We know how other neurological alteration, as well environmental influences. And when we talk about genetic predisposition, we should talk about the endophenotypes, this type of individuals that have a particular predisposition to have some common traits with neurodevelopmental disorders, as well a particular predisposition to develop a neurodegeneration. Also, we should consider the comorbidity between a substance use disorder and neurodegeneration. So the psychiatric condition that in both cases increase the severity of addiction, or also could accelerate phenomenon of neurodegeneration through, for example, neuroinflammation processes. And the vulnerability of some pathways that are involved in the physiological evolutionary context of the brain, for example, the noradrenergic pathway, but also the dopaminergic pathway, that they are the last pathway that are going to have maturation delayed in this case. Also, the neurodegeneration, as I told you, that predisposed to develop a toxicomanic process. Just to have a global overview of this mechanism that are fully explained, extensively explained about the neurotoxicity processes, the oxidative stress, and also the mitochondrial dysfunction, phenomenon of neuroadaptation like, I don't know, downregulation or upregulation processes, the disruption of several neurotransmitter pathways, and also the neuroinflammation, that is the most commonly spread pathophysiological mechanism. So this could be translated in different damage in different areas. For example, the abnormality in the reward circuits, as well in the cortex, mostly in the prefrontal cortex, also in the alteration in general in the limbic system, so it could be involved also amygdala and the hippocampus, and this could lead to an impairment in executive functions and in the striatal integrity. This is just a scheme to sum up what I told you about the intricate relationship in which we have to understand how some dimensions overlap the other ones. And let's talk about the specific cerebropathies related to the substances. We choose these three substances because of their clinical prevalence. We we choose this one because they are the common, maybe, substance abused, and also because they act in different pathway, and we could find distinct evolution basing on the specific action of each one. We know that alcohol acts especially mostly in the GABAergic system, but also in the long projection pathways involving glutamatergic 1. On the other hand, we know that cocaine involves the dopaminergic systems as the main pathway struck by cocaine. And also we know that heroin hits opioid system, but also, as Angelo said, the dopaminergic 1, inducing a neuroadaptation in both systems also. If we take, for example, this scheme that then we will apply in the case of heroin and in the case of cocaine, basing on, this is all MRA and PET studies, basing on these findings, we can find that the primary regions struck by alcohol use, continuous alcohol use, are the front lobe, the cerebral, and also the hippocampal and limbic regions. Obviously, these regions, the damage on these regions has clinical symptomatology associated. We have alcoholists with a clear clinical presentation with executive dysfunction, in which we can find a worsening in their functioning. Also at 50, 55 years, they present themselves with difficulties in their work. So we have also gait instability, as well memory deficits. So basing on the damage in each regions, we could have a variable range of syndromes that goes from the well-known Korsakoff-Wernicke syndromes, goes to the frontal lobe dysfunction, alcohol-related. So we have a spectrum of different clinical phenotypes basing on this anatomopathological substrate, the ARBD. This is the damage directly related to the alcohol use. We know that alcohol could cause neurotoxic effects directly and also indirectly, and stimulate, triggering neuroinflammation processes, and create this anatomopathological substrate, the RBD. And then, following the obviously genetic predisposition and other risk factors, we could have different phenotypes. So we try to apply this model considering the hearing, considering the action of hearing. We know that in general, hearing has an action, exercitate a damage that is symmetrical in the white matter. And depending on the way of using of the heroin, we could have different regions measured, mostly struck by heroin. We could have subcortical and limbic damage in general, but we could have the posterior limb of the internal capsule, so with other clinical symptomatology, distinct symptomatology, and also a sparing in the subcortical U fibers. So the associated clinical symptomatology is strictly related to the brain regions damaged by the substance. So what we see in our patients, we see in our patients difficulties in impulse control that we tend to attribute to another comorbidity, for example, psychiatric comorbidity. As well, we see mood dysregulation, and we tend to say that there is another comorbidity. But in longer hearing users, these two dimensions could be the expression of a neurodegeneration related to the hearing use. And also we could have motor abnormalities, so the predisposition to have some simil Parkinsonian neurological signs, for example, bradykination, or, for example, the predisposition to develop EPS following an antipsychotic therapy. As well, the psychiatric disease or secondary psychiatric disease. So the spectrum of clinical variants in the case of hearing is very wide, in which we have cognitive alteration, simple cognitive alteration in the impulse control, as well emotional dysregulation associated, for example, to motor abnormalities, till the clinical presentation of what we call leukoencephalopathy. Leukoencephalopathy is like, also in this case, anatomopathological substrate, is like a neurodegeneration, a spongiform degeneration of the wet matter that could be wide and diffuse in also in all the brain. And this is the different in distinct pattern of leukoencephalopathy basing on the way of using. So with different clinical phenotype, with different clinical signs. And if we apply this model to also cocaine, what we can say? Cocaine disrupts, firstly, dopaminergic system. So all the pathway involved in dopaminergic system. So we have the mesolimbic one, so the reward circuitry, obviously. So we have the mesocortical pathway, and we have the association between prefrontal cortex and also subcorticals one. We have also the nigrostriatal. So we have the difficulties in control motors through also the action on detrimental effect on cerebellum. But also we could have temporal lobe dysfunction. This is the EEG studies. So what we see in the associated clinical symptomatology, like we have executive dysfunction, is very similar to an ADHD clinical presentation, but related to the neurodegeneration. So we have a primary executive dysfunction, so the patients are not able to do the same things. Also, we have motor deficits, so we have also in this case Parkinsonian symptoms, but not only, because we could have also hyperkinetic symptomatology, so different cases. And also we have psychiatric symptoms. So the last part we will see in the next slide. We could also observe like a trend of neuroprogression basing on the severity of the addiction and the quantity of cocaine using also. And it's important to say that the cocaine acts on different systems, on the dopaminergic on one hand, and also involving mitochondrial dysfunction, mechanism of apoptosis, as well the VMAT2 system, and other systems that led to different clinical phenotypes, neuromotor syndromes, as well neurocognitive syndromes. This is the neuroprogression that we have observed in our sample, in which the first manifestation are now neuropsychiatric syndromes, maybe the majority of the case mood dysregulations and also mood instabilities, but also we have sleep disturbances and also reward deficit syndrome that amplify the cocaine use disorder. So these are the first signs of a neurodegenerative progression related to the cocaine use. Then we have executive and motor deficits. And in the final stage, we have also a multi-domain deficits in general. So in which other, obviously, brain regions are involved. For example, we could have other psychiatric symptoms like OCD symptoms or also psychotic ones. This is a comparable table in which we divided the type of the primary target regions struck by each substance, and we can see how it could be different, the associated clinical symptomatology, and also the spectra of clinical variants that we have. And this is a link between the presentation of mine and the one with Angelo, because we know that neurodevelopmental disorders predispose to neurodegeneration. We have a lot of studies linking ASD or ADHD to a precox deterioration of some circuit. But we know also that neurodevelopmental disorders, as Angelo said, predispose to addiction. And above all, what we noticed is the last sentence. We know that the trajectory of became an addicted patient is faster. So the time that goes from the first touch to the substance to develop an addiction is faster. So is a clinical remarkable finding that we have every day in our clinical practice. So we try to apply this theory in the context of viewing, obviously, neurodevelopmental and neurodegeneration. The theory of the last in, first out, IDEPST, the last circuitry that go to maturation are the first that goes to a neurodegeneration. So it's incredible. It could be the perfect storm in this sense, because not only the subject with a neurodevelopmental disorder has a major risk, an increased risk to develop a neurodegeneration, but also a substance use disorder, and also a neurodegeneration related to the substance exposure. This is like a vicious cycle in which everything feeds the other elements. When we have a neurodevelopmental disorder with some structures that predispose the subject to use the substances. Okay, I'm trying to, okay. And we, for example, executive dysfunction or impaired impulse control that exposed to the substance abuse, and also the lack of resilience, the synergistic damage, neurodegeneration, and also neurodegeneration predisposed to feed this cycle. This is what I have already said. Obviously, that some cortical areas are strictly involved in the addiction process, and the paraphysiological evolution of this substance could predispose to develop an addiction. What we have on a clinical and therapeutic point of view, we have just a few instruments to treat these patients. So we need to early detect this condition. So the clinical assessment, our clinical assessment, it's very important, because we need to recognize the neurological symptoms that these patients could present. Also, we need to recognize the specific psychopathological expressed by the patients of substance users. And also, we need to integrate this information. And it's important to know what we have to do. This is an algorithm of decision-making So sorry for the color, but okay. So when we have a species of a neurological condition, we know that we could use some neuroimaging instrument. We could use PET, we could use MRA, and somebody could use the functional MRA. But also we could use the neuropsychological test. So we need to assess, to understand what we have. And about our pharmacological intervention, we know that mostly the patients has a comorbid psychiatric condition, and we have to know that some drug could have also beneficials, but also detrimental effects. If we take, for example, into consideration the use of antipsychotics, is incredible how they act, obviously, on the psychotic symptoms, but could worsen the executive dysfunction, could work in a detrimental way on the motor symptomatology. And the same reasoning we should do for the SSRIs that are very important in treating depression, but we know that they could act on the salience, they could act on the aggressiveness and other aspects. But as Angelo said, if we have, in this case, a history of ADHD, we have to treat as early as possible. We need to intercept the trajectories. And also we need to act on the substance use. For example, using opioid medications to try to slow down the process of neurodegeneration, and also acting on anti-craving. We have to use all of these instruments. About the non-pharmacological interventions, this is not my field, but there are a lot of studies that explain how it is important to target with specific cognitive exercise to also, in this case, slow down this neurodegenerative process, this neuroprogression. As well, the TMS, some interesting studies, for example, in the upper part of the frontal cortex. So, in conclusion, this is the last slide, my promise. This is the take-home message. We know that neurodegeneration and substance use disorder are very linked, are strictly linked each other in both ways, considering the neurodevelopmental, but also considering the other part of the lifespan of the subject, the neurodegeneration. So we could have distinct neuroimaging patterns that led to different clinical phenotypes, and we need to have a comprehensive clinical assessment so to could integrate and could set up a personalized treatment. This is just the future directions in which, for example, in our field, we are studying the application of, for example, the psychedelics in this context, or also to slow down the neuroinflammation processes, or we are studying also the gut-brain axis. So we need to improve our knowledge in this important dimension. Thank you for your attention. Sorry.
Okay, we also thank Dr. Carbone for his engaging talks. Are there any questions?
Thank you very much. From a clinician's perspective, to be able to distinguish between the neurodegenerative causes and the acute and chronic SUD causes of either neuropsychiatric or neuromotor problems, I just go like this when I think of trying to do that. I'm like, you know. So, and I can't PET scan everybody. So is there something, at least basically, clinically, that you've found that could be helpful, or, yeah, well, that's for questions. It's mine.
No. I understood that this is a difficult dimension in general, and I know that there are a lot of concepts in these cases. Sorry. No, we need to know some conditions, some clinical conditions. For example, we has to know that the long-term heroin users could have emotional dysregulation, and at the same time we know that we need to treat that dimension with a specific pharmacological treatment, preferring, for example, mood stabilization, for example, lithium or valproic acid, if we can, because we know that they do not impact on executive function, that are also struck during the action of the heroin. And also we have to be careful using, for example, SSRIs, because they could increase the mood instability. So we need to know to assess the patients that we have in front of us, try to understand which dimension and which deficit he could have. So considering all these conditions, we have to do an armed reduction, I don't know, to select the appropriate drug or the collateral treatment, to have a personalized approach. I know that is difficult, because we know that there are a lot of neurological considerations, but right now a psychiatric should understand that the patient could have a dementia or a neurological condition. And it's not enough to say my patient has dementia. We have to know which type of dementia they have, because it's another trajectory, it's another condition. And at the same time, if we send, in Italy is in this way, if we have a suspected of dementia, we send the patient to the neurologist. The neurologist said, no, it's a psychiatric condition, and resend him to us. So the psychiatric should know these dimensions. So it's important also applying this model in the addiction field, because we know that substances have different detrimental effects in different brain regions. Thank you. No, I don't know if
If you have no other questions, we could conclude the symposium. We thank our three speakers, and thanks to all of you for participating in our symposium. Vai ora.